Like I said, my name's Leslie. I'm a child and adolescent and general and addiction psychiatrist. I work at the IU School of Medicine as a faculty member there. I see patients in an outpatient clinic. I also work at Midtown Mental Health in an outpatient capacity. And then our department has a contract with FSSA, the Division of Mental Health and Addiction, to provide medical directorship. So I have a cubicle here, and I come over here a few times a week and get to take part in this very interesting work as well. So what we wanted to do today was to crystallize some of the observations that have been coming up over the last few months, and like Allison said, the level set around some of the concepts with ASAM. So I changed the outline a little bit from what's on the piece of paper, so pardon me, that was kind of last minute. But we really want to just kind of overview the treatment criteria, how that works for ASAM, and the way, this is all derived from the book, so this is the thing to get if you want to know about ASAM. Many of you probably already have it. And then we'll talk about the levels of treatment that exist in this continuum, how they're assessed, some red flags, screening tools that are in the appendix. They make some notes on special populations within ASAM, and then a discussion about when to admit with regard to withdrawal symptoms. And then we were hoping to have some time left for case discussion, so we could present some examples of cases. I have some that I can share, or if you guys want to throw some out there to the group and see how we respond, we can do that as well. And then we wanted to leave time for questions, comments, and concerns. So I'm going to try to zip through the content quickly, so we have plenty of time for that. So ASAM, American Society of Addiction Medicine, that's the acronym ASAM, right? It's been around for a while, founded in 1954, and they've spent many decades trying to come up with a series of criteria so that everybody can speak the same language, whether it's in clinical or research settings. It used to be known as the patient placement criteria, but they changed that. And the criteria themselves have only been around since the 80s, really. And it's the only set of them that exists like this. So it's not like there's competing models. This is really the only one. And they've become the most widely used criteria and set of guidelines around placement for substance use disorder treatment, continued stay, et cetera, in the world, I think. And they're required in over 30 states. So Indiana was not very involved with ASAM up until the waiver, right? And now we're getting to understand more about what they mean and how to use them. So it's all very new for us. The version that we're using now is from 2013. That's the newest version. They have separate placement criteria for adults and adolescents, and the goal is to use these to help with the treatment plan. And it assesses individuals over 6 dimensions, right? So it's not just on their substance use. It's kind of, a challenge to learn them, right? This is a really enormous book full of a lot of information, and so it's hard to immediately get it all. So, the book is one option. They also sell the computer-guided interview, ASAM does, called Continuum. And there's all sorts of different options that one can utilize that they sell. In recognition of the cost of that, DMHA has begun, or I shouldn't say has begun, we're making our way through and close to the end, a process of developing a crosswalk between the CANS and the ANSA, which is required in Indiana for DMHA certified providers and ASAM. So the scientist in me is curious to see how it turns out, but I'm hopeful that it will be really helpful and innovative way for providers to be able to mesh these two pieces of data. The CANS ANSA score and the ASAM criteria. So stay tuned for more information on that. So broadly speaking, and again, this is probably a review for everybody, but there are 5 levels of treatment, really, that broadly speaking, ASAM identifies. And Indiana certifies currently 2 of those, right? So 3.1s and 3.5s, but the goal is to get to a full continuum, or designates, right? Is that the right word? Designates providers with those numbers. But the goal is to get to a point where the state is able to designate all the levels. And I think an important way to think about this is that the population of patients that exist in the state are not going to be evenly distributed across all of these levels. So we actually expect that most people will do better or have an adequate response if they're like other states and other nations in lower levels of services like outpatient treatment, and that a much smaller percentage will end up in, so for example, a level 4. If it's like any other disorder, and opioids in particular, right? So even though we're going to spend a lot of our time today talking about the inpatient levels of care, because that's the work that these folks are doing, it's a relatively small percentage of the state's population that will be involved with that level of care. And so ASAM also, sort of confusingly, has this separate level of designation for withdrawal management, right? So they have levels 1 through 4. So this was all just general levels of addiction treatment. And here they also have these withdrawal management levels, and so they call them like level 1 withdrawal management, level 2 withdrawal management. And those start with ambulatory outpatient treatment that may or may not have on-site monitoring. So you might do it all at home, or you might do some of it in an office. And then they jump up to clinically managed residential with 24-hour support, and then medically monitored, and then medically managed. So those are all just within withdrawal management. And they make a big deal out of how they're not talking about detox anymore. That's not the terminology used. They talk about intoxication management, which is different than detox, but withdrawal management is the terminology that's preferred within ASAM now. And one section that I want to call everyone's attention to that I think is so relevant here is not a small section, but pages 147 through 164. They have these risk rating matrices that are detailed in the manual. And they actually break them down. So they have many pages dedicated to rating the risk of alcohol related symptoms, alcohol use symptoms. And they have a big chunk on sedative hypnotic symptoms. And then they have a smaller chunk on opioids. And the reason for that is the risk of harm to somebody with withdrawal symptoms is great with alcohol use disorders and sedative hypnotics. So it's very important to figure out the right level, right? Less risky with opioids, and then very not risky with other drugs of abuse like tobacco, marijuana, and stimulants. So they are very careful with the disorders that are more likely to cause morbidity and mortality in withdrawal, which would include alcohol and sedative hypnotics. They spend a little less time on opioids. But those are great sections to really figure out, where should this person go? And so I was hoping in our case discussions we could use some examples from there. But if I were you and I was not familiar with the ASAM manual, that's where I'd go first, because I think it's most relevant to the work that we all do. So what happens is the method allows you to generate a risk rating score, and then they map that score onto the service needs and level of care required within these risk rating matrices. So again, it's like 10 pages dedicated to alcohol with like 20 different clinical scenarios. And then when you get to tobacco, there's like one little paragraph, marijuana, like 3 sentences. And basically they're saying withdrawal from tobacco, marijuana, and stimulants is not dangerous. And so they're going to be level 1 unless there's something very bizarre happening. So that's why those are such a brief overview. So you're not going to admit anyone for marijuana withdrawal to a level 4. Really, is what they're saying, unless something really odd is happening. And in general, they give a lot of examples, and one observation of mine was that they repeatedly suggest starting with lower levels of intensity, meaning the least restricted environment, which is a concept in mental health and addiction that is, embraced federally, right? That if someone can do well in an outpatient environment, we want to give them a shot at that, because they can maybe keep working and see their kids and sleep in their own bed at night, if possible, right? So that's generally the framework, it seems to me, within ASAM that's encouraged. And a lot of times you'll see higher levels of care comments in their clinical examples within these matrices are warranted once other levels have been exhausted, or once other levels have failed. Then they're suggesting other higher levels. So I'm just noting that repeatedly came up in the examples within the matrices. I just want to comment on how ASAM views 12-step peer support and self-help treatment options. And basically, they're very explicit that these, AA, smart recovery, you name it, whichever one you're talking about, are not formal treatment programs. So they do not view them as treatment programs, but they do note that they are very valuable as lifelong support systems. And so we should not think that because someone's going to a 12-step group, that is a level 2.1. But they note that providers integrate these modalities into all levels of care. That's fine, but they are really an adjunct to treatment. And they have a bunch of different terms, and we don't have to spend a ton of time on this, but it's not intuitive, I don't think, unless you read their definitions. So they use the term clinically managed, and what they're talking about there is non-physicians, non-medical people are handling the care. So these are primarily emotional, behavioral, cognitive, readiness to change, relapse kinds of focuses within treatment. And intoxication, withdrawal, that kind of potentially dangerous, risky stuff is not really part of the treatment within a clinically managed setting. Medically monitored would have a heavy dose of nursing, interdisciplinary nursing, counselors, social workers, addiction specialists, and it's a medical protocol, but it's not, the doctors are not sitting there checking in constantly or regularly. I mean, regularly, yes, but not frequently. So we would expect coverage, we would expect a physician by phone to answer questions, but in the medically monitored settings, we would not expect the physician to be in-house super regularly. Whereas the medically managed, in the ASAM lingo, are services that do involve daily medical care, diagnostic and treatment services are provided or managed by the appropriately trained and licensed physician and physician extenders. So I think those words kind of blur together for most of us, but in the ASAM world, they mean something very distinct. And this is just an overview, which again, there's literally hundreds of pages dedicated to talking about these dimensions, but the point is ASAM uses a bunch of different things put together to determine the level of need for a person, and dimension 1 is the intoxication and withdrawal, then the biomedical complications, which there may be some, there may be none, and then emotional, behavioral, and cognitive conditions that might complicate things. Sometimes I find providers get that confused with psychiatric treatment, and it really isn't a substitute for psychiatric treatment. It's just the components of the emotional, behavioral, or cognitive aspects of the substance use disorder are part of it. But if they make a big point of, if somebody needs psychiatric services, they need to go to get psychiatric services. They're not necessarily in the same place. And we don't assume that because it's an inpatient unit that they necessarily have inpatient psych. Which I think is a really big shift for us in Indiana, where that's what we are used to. Inpatient means inpatient psychiatry, and in ASAM world, that's not what it means necessarily. So that's one thing that we've learned along the way is very complicated. Readiness to change is important, right? Of course, and then relapse, continued use, continued problem potential, so the risk that someone continues to pose, and then their recovery and living environment. So it's really multidimensional, which I think all those of us that work in the field very much appreciate, right? And then this is sort of not within the ASAM framework, but kind of like the world we're used to, so I thought it'd be worth mentioning, right? So inpatient is, the most intensive level of service, right? We have 24-hour structure and support, 24-hour access to medical and nursing support, imminent danger kinds of situations historically in psychiatric world, and then also for substance use disorder treatment. Whereas residential, still very structured, still a lot of support, 24 hours a day, not necessarily a physician right there, but the medical services typically are not, the primary medical services are not the focus, but we could still find some imminent danger at the higher levels, but those dissipate as we get into lower levels of treatment. And then outpatient, provides quite a lot of structure and support still, not necessarily having the primary medical support, so we would not expect to see folks who are in imminent danger in that situation. And I think important to remember, outpatient, as they define it, is not 1 hour a week. It could be up to 9 hours a week for adults and 6 for adolescents. So it's still a fairly heavy dose of treatment in many cases. So again, here's our reminder of the continuum. So just to walk us through the early intervention, actually I'll just skip to my next slide where I have more detail. But you can see that, we basically go from barely even an intervention. You don't even have to have a use disorder. Maybe this is a court-mandated thing because you have a DUI, or an SBIRT intervention in a primary care setting for 0.5, up to outpatient services, which are actually specialized treatment providers, pharmacotherapies, psychotherapies, groups, etc. all the way up through the partial hospitalization, intensive outpatient, still outpatient, right? And then 3 is where we jump to residential level. 4 is where we jump to inpatient within the ASAM continuum. So we'll go through that in a little more detail here. So level 0.5 is actually not considered a level of care or treatment, but it's kind of psychoeducation, prevention, could be a brief assessment, and if the assessment indicates the need for treatment, then go forward with treatment. So like I gave you those examples already. And then outpatient, again, we'd expect fewer than 9 hours of contact per week, but still quite a lot of treatment is available in the outpatient setting. And then intensive outpatient is 2.1, right? So by definition, ASAM says that must be 9 or more contact hours a week in a structured program. It could be 6 for adolescents. And the level 2.5, what we would traditionally call a partial hospitalization, is 20 or more contact hours. So a big jump between IOP and partial in terms of the number of hours per week, again, structured. Just reminding us where we are there. So moving up to the residential levels, right? So we're really, ASAM says residential is for an inpatient. This level here, well, they specifically say residential is for people who need safe and stable living environments, right? So if you have a safe and stable living environment, ASAM says probably you don't need residential. So 3.1, an example of that might be a halfway house or sober living, something like that. This is a clinically managed, so meaning clinical staff, social workers, peer recovery folks, low intensity residential service. So not a physician around necessarily. We would certainly expect medication-assisted treatment to be utilized or offered at least for everyone with an opioid use disorder, often for folks with alcohol use disorders, et cetera. But it's not a hospital, right? And then jumping up to and Indiana, recognizes 3.1s currently. And then 3.3 is a really interesting one, I think, and we do not have this recognition in our state right now, but and there was, I guess, a big change in this most recent manual for this version. So what that means is these folks have cognitive impairments. Maybe they have traumatic brain injuries, maybe they have intellectual disabilities, and they cannot sit through a level 3.5 day because of their programming needs. They just need different services. And so a special place for those people who still have very intensive substance use disorder needs, but who can't handle the cognitive behavior therapy, that kind of thing, because it's not as effective with folks with cognitive limitations, would be served in a 3.3. That's the way, so that might be a therapeutic rehabilitation facility, for example, but the focus is on the substance use disorder. And they just emphasize that even though it's a 3.3, we're not trying to say they don't have intense needs, it's just a different array of services provided. The 3 point, and that is not, they do not designate that for adolescents. So I don't know what you do if you're an adolescent with cognitive limitations. The ASAM doesn't know where to put you, but you would not go to a 3.3. 3.5 is a designation appropriate for adolescents or adults, depending on the setting, and that's the clinically managed, again, not medically managed, but clinically managed high intensity. So a lot of treatment being provided, high intensity, they're living there. Our traditional residential treatment center model would be the 3.5. So for folks who have unstable, unsafe living environments, and they work through the matrix and end up needing there, who don't have the medical problems that warrant the higher levels, this would be where many of those folks would be. The level 3.7 is where we add in the medical complexity, right? So the medically monitored, not the medically managed, but the medically monitored, meaning we have access to physicians, they're not there all the time, but there's nursing available. So it's a pretty intense level of services, and there is a way to provide that treatment for adolescents as well, according to ASAM. And then the very highest level is the level 4, so they do not consider that level to be residential. That is inpatient, right? And so that's equivalent to what our inpatient units are like, I think, in many cases here in Indiana. And this is the medically managed intensive inpatient treatment. So this is where the medical concerns are really imminent, at front of mind, and so the physicians are right there, along with whatever other physician extenders are, licensed and able to provide that work in that state. And the medical comorbidities are really prominent in this treatment level. So when we think about withdrawal management, the way they break that down, again, we have these different levels for withdrawal management, right? So we have ambulatory, they call it, the first one, the least intensive, is ambulatory detoxification without extended on-site monitoring. So that might be a physician office or a home health care site that you come in, you get your script, and you go home. Ambulatory detoxification with extended on-site monitoring, maybe that's a partial program where you come in and you have somebody monitoring you, but you go home at night, but you're still an outpatient. And then level 3 for the withdrawal management levels. And again, we don't have these designations in Indiana at this point, so I'm just letting you know what ASAM says. We would expect level 3 there to be clinically managed residential detoxification. And then we have the other level 3 is medically monitored. They have 2. And then they have the level 4, the medically managed detoxification. And then they categorize the opioid treatment programs, what we would call the methadone clinics, in a separate category. They just they don't fall into any of these level 1 through 4s. They have their own category. And they are, by definition, for ASAM, for folks only with severe opioid use disorder.
So, and I kind of want to flag, I think we're entering sort of one of the areas where we've seen a bit of disconnect play out between some of the higher level providers and health plan. We try to not be a triangle here at the state. We try not to have health plans, state, and providers. But frankly, this is a space where it seems like we have some disconnect. So I just kind of want to, I know we were all listening, but I want to really emphasize, I think we're entering the space where this is significant, because I think this is after seeing kind of the back and forth and the maturation of the program and the feedback. This is our attempt, DMHA's attempt to kind of crystallize some of this and convey what we think all of this means and what to expect. There still may be inconsistencies, but this will at least help us identify, for us to level set and say what we're seeing and what we, the people that are qualified to have thoughts like this, think. So anyway, just flagging it, because this is an area where this is kind of why we brought you here. We want to talk through this. Okay. I'll give it back.
Yeah. So, and just a reminder that kind of hit on this earlier, but the types of withdrawal vary very dramatically in terms of their clinical presentation and in terms of the outcomes that are possible for patients. So, potentially dangerous, potentially life-threatening withdrawal can occur with alcohol use disorders and sedative hypnotic, particularly benzodiazepine withdrawal. So those are, ASAM dedicates a ton of time to figuring out what is the right place for those people, because high-risk situations there. Uncomfortable withdrawal, very, very, very rarely dangerous or life-threatening, would be things like opioids or nicotine withdrawal. Minor withdrawal, so not pleasant at all, and often, if I had $1 for every time, a person with a cocaine use disorder ended up in the ER saying they were suicidal in my lifetime, that would be paying off my loans. It's not like absolutely no big deal at all, but in terms of are you gonna die, cannabis and cocaine, at least in terms of medical symptoms, are not thought to be dangerous, just uncomfortable. Let's see. So the goal really is to individualize the treatment for people, right? We have the patients, the problems, the plan, the priorities, the 4 Ps, and then we manage their severity of their disorder with their level of functioning and try to figure out what the right intensity is, right? And so ASAM's really big on, just because someone didn't do well on a particular level before doesn't mean they don't need that again, right? So we base it on the here and now. Their life circumstances might have changed, and so now we reconsider every time we see someone and think, what is the right thing for them at this moment? And some red flags that they note throughout are imminent danger and imminent need. So how do we define those? So imminent danger would be defined here as a strong probability that certain behaviors will occur. So we are confident that this person will continue to use drugs, relapse, or have non-compliance with something. So it's extremely likely that it's going to occur. The likelihood that it will be problematic for them, that it presents significant risk of adverse consequences is high. And then that likelihood is occurring in the short term, right? So it's very likely to occur 3. So if all 3 of those things are happening, we have imminent danger. That's how they define that. And then, so we're looking at trying to, so several of the dimensions address this. So in terms of the acute intoxication or withdrawal, have you ever had life-threatening withdrawal symptoms before? So if that answer is yes, that's a huge deal, right, for especially alcohol. Are you currently having withdrawal symptoms? So that's where we begin to figure out that imminent component. Do you currently have untreated severe physical problems, right? So if you have some horrible medical condition also occurring, maybe related to the opioid use disorder, that's really important to know at that moment. And then in terms of the dimension 3, that's getting more around suicidality. Are you imminently in danger, or could you harm someone else? Homicidality. So those are the immediate need items that are, really essential within ASAM. And then within 4, do you feel you're in imminent need of alcohol drug treatment? Have you been referred or required to enter treatment? So those are the things that allow us to get at these immediate need or imminent need. Are you currently under the influence? Are you likely to encounter dangerous behavior with your use, etc.? How about people around you? Are people around you threatening your safety, your well-being, your sobriety? Those kinds of questions, right? Very important. So if we're seeing lots of yeses, and again, this is kind of training like for folks who maybe aren't clinicians. So yes to those dimensions 1, 2, and 3 are we really need urgent medical or psychiatric care, and maybe that means not in an addiction treatment center first if someone's imminently suicidal or having some really out of control medical situation. Dimension 4 alone, just a reminder, that was treatment acceptance or resistance, right? So if somebody's pretty motivated, but they're not having imminent medical or psychiatric care, ideally we should get them in for an assessment quickly within 48 hours, but not that hour. The goal would be to engage them with motivational strategies if they're not interested, unless we're concerned they're imminently going to walk out and they need some sort of containment, then we look for higher levels of care. Yes to dimension 5, so that was the relapse continued use potential. So are you under the influence? Are you likely to continue to use? We need to assess around withdrawal. And then yes for 5 and 6. That's the recovery environment and the relapse use. We need them to be referred to a safe or supervised environment. And I think one of the points that we've really want to emphasize today is that everybody involved with that person, whether it's the provider or the managed care entity, really needs to jump in and assist that person in the moment when we find that we don't have the right place for them that day. So that might mean transitioning to a different place, finding a different provider that does have, if that person is at a 4.0 and they really need a 3.1, a lot of collaboration around getting them to the right place. So I think that if there's probably one thing we would all agree, that is it.
And I'll find that is something we've talked about in our SVD work groups, and I think we will continue to look at, so I think we'll probably come back to this, but what options are health plans presenting when that denial comes or when that conversation happens, and what are providers doing in terms of rounding out that continuum of care, doing the injunction. So injunction, right? That's the right word. MAT started. So induction. That's probably a legal word, right? Anyway, I want to kind of reaffirm that. I've taken a note, so I'll put out. You keep going. Okay. Yeah. So sometimes we've got to figure something out this hour. And one thing we do at DMHA that is not my favorite thing we do, but we review all the medical records of people who die. And we see so many people in our state dying because they show up and they say, hey, I need help. And someone says, okay, we're going to assess you. Come back in a month for a psychotherapy session. And if you attend 3 of those, then maybe you'll get to see a prescriber. And they're dead before they ever make it. They need the buprenorphine that day. So our goal in our system is to really get access to care quickly. And some disorders, panic disorder, there's lots of disorders where people can wait, but opioid use disorder in particular is not one. So we want our systems to be primed to respond quickly, and that needs to be all of us working really hard to make that work. Okay, so the ASAM manual spends a lot of time, manual and therefore organization, prioritizes a few different populations that I thought were worth mentioning. So there's special sections on particular treatment needs for older adults. They spend a lot of time dealing with Medicare population and those with mobility needs, things like that.
And then they have, which I thought was really interesting, and I'd love to see our state get into this more, treatment for parents or prospective parents who want to receive their treatment concurrently with their young children. So they don't want to be separated from their young children. This could include women who are pregnant or postpartum, but it could also be fathers who are parenting or others, and they have a whole special series of treatment recommendations and way to make that work. That others, that people around the nation have figured out. And so that was great to see, because obviously attachment being a really important part of development. And then there's a whole section on persons who work in safety-sensitive occupations. So these could be police, healthcare workers, airline pilots, attorneys, folks who need some special attention to make sure that they can continue to do their jobs. And so they have a lot of recommendations there, which is very helpful. And then, of course, persons who are in criminal justice settings have very different treatment needs sometimes, and how to engage and interact effectively with the criminal justice other folks, that they have a lot of good information on that. And then they have a special series of matrices for people who also gamble, in addition to have substance use disorders, which was very interesting, and how to customize treatment for them. And then I know I mentioned earlier they just have like 3 lines under the withdrawal management section for tobacco use, because they think that's not a dangerous, scary withdrawal. But they think tobacco use disorder is incredibly important and undertreated and resulting in tremendous amounts of morbidity. So they actually have an enormous section on how they think addiction professionals should be addressing tobacco. It should not be sort of left out of the treatment plan. And so it's just a reminder that that's a priority within ASAM, and we should all strive to keep it on our radars and continue to focus on that too. But I just thought that was interesting. They literally have like 10 pages on why that's so important for treatment with other use disorders, and what, how to integrate that, how to handle some of the barriers that come up. And just a note that some of the withdrawal scales are actually in the manual and available. So the CWA for alcohol withdrawal, the revised version is in there. The COWS and the CINA, which are opioid/narcotic withdrawal tools, are in there. And then they have the nicotine dependence, the Fagerstrom one. So all in there, which is great. And then just again, my observations over and over, if you read the examples and you get in there, they recommend starting with lower levels of treatment intensity and move to higher levels as the individual needs them. And on our view, looking at data in our state and nationally, is that most people are going to do well, at least to start off, with outpatient treatment. So we need a huge number of outpatient providers, and I'm guessing some of the frustration with inpatient providers is finding those providers. So we are well aware of the need for more of that to occur in our continuum.
And I guess maybe I would flag too, because some of the takeaways from the ASAM training was that kind of specific note that it's sort of a rare. Can you comment? I think that's what you're getting.
Yeah, I think we're good.
Yeah, you're going to.
Well, so I guess maybe we should be more explicit about that. So in the examples we can talk about that, but. They're very clear that a level 4.0 is not uncommon for an alcohol use disorder, not uncommon for a sedative hypnotic use disorder like a benzodiazepine withdrawal, but quite rare for an opioid use disorder. So there just aren't very many people that will meet, that in the world, who will meet level 4.0 treatment as ASAM defines it with an opioid use disorder. Because the requirement is that the medical, it's not, and I can read it to you actually, what it would say that you essentially need to have. So to meet a 4.0 withdrawal management for opioid use disorder, so level 4, we would be looking for someone who has the following, right? Debilitating vomiting and diarrhea. Now every single one of these says vomiting and diarrhea, like that's normal, but debilitating vomiting and diarrhea, agitation, gross tremor, fever, severe elevation of blood pressure or pulse. So really very sick people, medically very sick people for level 4.0. So even just to think about, well, okay, so what are we talking about for outpatient? Well, those people the very mildest cases of withdrawal would have occasional yawning, slight pupillary dilatation, right? So their pupils are dilated a little bit. Chills, mild anxiety, runny nose. So those people, they say level 1, maybe level 3.2. We're still in outpatient when we get to frequent yawning, abdominal cramps, nausea, loose stools, body aches, mild elevation of blood pressure or pulse, moderate sweating, anxiety, tremulousness. So those people, they sound kind of scary. I mean, when you read all those things, but ASAM still says, no, that's outpatient withdrawal management. Even vomiting, diarrhea, observable tremor, mild fever, moderate elevation of blood pressure or pulse, significant anxiety, sweating, and restlessness, body aches could be treated in an outpatient setting depending on the other psychosocial factors according to ASAM, level 2. So the bottom line is one has to be very medically unstable, and this is the risk assessment matrix for opioid withdrawal. That's where I am on page 162. So if we say we're following ASAM, that's what we're looking for level 4. Okay. So this other issue has come up a lot about, well, how far into withdrawal should someone be before deciding on treatment? And I don't know if I don't think it's a super straightforward answer. It's my medical opinion, so we'll talk about that. So addiction folks will tell you we really aren't supposed to start buprenorphine, induce it, until someone's clearly in withdrawal, because that's how you know they need it. So we need them to be at least in mild withdrawal. But let's say they've been taking methadone or some other long-acting opioid, then we need them to be maybe in even more intense withdrawal to be confident that we're not going to precipitate a very uncomfortable situation by adding buprenorphine. So, and then naltrexone, for example, if we're going down that path, that cannot be started even until someone hasn't used for, let's say on average 7 days. That's a really tricky thing to get through for many people. So in many cases, we would want that process to occur in a confined, controlled setting. But we know opioid withdrawal. So that's on one side. We know that we've got to wait until until they're in withdrawal. Nobody should start buprenorphine until you're not in withdrawal. I will say there's a few rare examples of like adolescents who don't have a steady supply and you're still worried about them using, but. Anyway, for the most part, we would not want to start this until we're confident that the opioid, they're in withdrawal. That's every treatment protocol you read will say that. But we know that opioid withdrawal is inevitable for people that have moderate to severe opioid use disorders. So if we're confident that they're going to emerge, there's no question about it. They have an opioid use disorder. It's only a matter of time until the withdrawal begins to emerge. My opinion is that we should proceed with the treatment, whatever that is, whatever level that is, and not send them home, not wait for the withdrawal. Unless we're doing an actual induction in our office, then we say we'll come back in 4 hours. But if we're talking about a residential stay or something like that, and we know they have an opioid use disorder from years of documentation or whatever it is, my clinical opinion is let's get them into treatment right then if they're willing. But if you're not sure, which again it would be pretty rare that someone's trying to get admitted for an opioid use disorder who doesn't have one. You can imagine like when it's 40 below and you're working in an emergency room, there's going to be some folks coming in saying, "Oh, I'm suicidal. I don't know," who maybe don't because they want a warm place to stay. There are situations like that occur. So I can imagine in those situations you might say, "Well, let's confirm that this is in fact an opioid use disorder," if you're not sure. In those instances, I could imagine you'd want to wait to confirm the withdrawal, but those should be quite rare, I think. Most of the time you're going to be pretty clear that someone has an opioid use disorder and that they do need treatment and that they will begin to withdraw within a matter of hours. So clinically, I think that the idea here is we want to strike while the iron's hot. If someone's there, they tell you, I'm injecting heroin multiple times a day, I'm ready for treatment, but I'm not in withdrawal yet. I think the right thing to do is to keep them there if you're pretty confident you've got that use disorder there, and then begin, because they're motivated in that moment, and then begin the buprenorphine or whatever the treatment is when clinically appropriate.
I will give the non-clinical perspective, because that is a conversation that we have specifically had in multiple venues and with the secretary as well, who's a physician. And correct me if I'm wrong, but my non-clinical takeaway from what I heard is we don't expect providers to have to tell individuals, hold off, you need to be in withdrawal before I can treat you. But on the other end, that shouldn't be an expectation of the health plans either. So I don't know where it's starting, but I think just to level set, if this is an area we can all agree, the withdrawal is almost irrelevant, or not really. I know it's nuanced, and it, depending on
with
if
opioids,
it is a snowstorm, opiates, but I guess I just want to flag.
As long as you're confident someone has an opioid use disorder, it's coming, the withdrawal is coming, right? So just go ahead and start treating, and then don't induce buprenorphine or whatever your plan is until clinically appropriate.
Because that's been some of the inconsistency back and forth. Does that resonate for anybody?
Yeah, but what you're saying specifically, the Dr. Hulvershorn, is this is true for somebody coming in, say, for example, residential treatment or other levels of care below that, really, not necessarily inpatient for opioid use disorder, because for inpatient the bar is pretty high for opioid use disorder.
Well, right. So we would expect there are a lot of medical comorbidities that would be part of the picture.
Right.
But withdrawal itself is not the bellwether. Is that fair to say?
Right.
Yeah.
For opioid use disorder, withdrawal itself is not enough to qualify for inpatient level of care.
Right. Yeah.
But it's not also enough to disqualify somebody.
Right.
So
So we don't want to see a denial that says not in withdrawal.
Sure.
Specifically. Does that resonate with health plans as well?
Now, if you are doing an outpatient induction of buprenorphine, you need to give that medicine in that hour. So it would make sense in that case to say, all right, come in, because we can't wait standing there for 2 days, or, but, so we're mainly talking kind of IOP and up with these, or partial and up. Yeah. Thanks for that point. Thank you for clarifying. Okay.
And just for another point of clarification, I'm sorry. So in level 4, the way that you describe that would apply if you were at risk for those conditions or presenting in those conditions.
Well, so for opioids specifically, you would need some kind of complex medical comorbidity to be occurring, or you could have some sort of complex withdrawal that has taken so long that you are now, your electrolytes are out of whack and you can't stop vomiting and you're dehydrated or whatever, to the point where you're in danger. It's hard for me to imagine that you couldn't get to that place if you weren't in withdrawal, probably for some period of time. But you could also have some other medical need that warranted that stay, and it's not the withdrawal. So I don't think there's a yes or no in that question.
Some medical need that would be worsened potentially by the withdrawal.
Yeah. So I think what ASAM kind of highlights is that inpatient medical, it's rare that inpatient level of care is needed for opioid withdrawal, which is what I was trained with years ago as well. But I think that's been a consistent theme, that inpatient level 4. That doesn't mean that someone doesn't need to be in a safe place with a bed and a door lock that's not their home. That's your 3.7, your 3. Other things. There's a huge continuum, and 4.0 is a tiny part of it. And that is reserved for those folks that have a lot of medical instability. So, because ASAM considers the 3s residentials, those would feel a lot like inpatient to those of us who have, spent time on units. There's still places with beds and doors, and you're not leaving necessarily. You're staying overnight. But in ASAM world, they don't consider that inpatient. That's considered residential. And I know we're talking about opioids, but just for the sake of clarity, for someone with an alcohol or benzodiazepine withdrawal kind of situation, we do not want them to advance down the course of that withdrawal process. We want to get that handled right away, and especially if they have a history of that. So this is a very different discussion for alcohol than for opioids. Just pointing out. So so I guess now is the time we've allotted for talking through a case. So I'm happy to generate one, prototypic kind of thing that we've heard about, or if somebody has one they want to in a de-identified way share and walk through what ASAM would say, specifically opioid use disorders.
How about we'll start with yours.
Okay.
And hopefully folks can stick around for a couple minutes, because I would, while we're talking, if that spurs a case in your mind that you've experienced and want to bring it up, let's try to hold time for a couple of those. Do you guys know mechanically, like in webinar land, we won't get cut off, right?
Oh, no.
Okay. Perfect. Okay.
Okay, so if we had somebody who is an adult, say a 32-year-old male, who has been using heroin intravenously for about a year and has depression, and otherwise pretty healthy person, presents with in withdrawal. So diarrhea, body aches, very uncomfortable. They tell you that their life is pretty unstable, that they're kind of couch surfing, living with different people, and they are ready. They're ready for treatment. They want whatever it is that works. And so they walk into your facility, and their blood pressure is off. So when you do your score, you find that, you know, this is definitely a withdrawal situation. They are trembling, they're restless, they're irritable, and their family is crying and begging you to please take this person into your facility. What should we do? So I'm just wondering if people would want to take a stab at what, if this was your facility, what would you do? Would you try to get your plan to call that person's plan and say, I'm trying to get them into a level of what? Just curious, just spur discussion and see what we think, and then we'll reference what ASAM says.
We would admit them, and unfortunately we would have to fax clinical for the plan to review.
Mm-hmm.
We'd only do level 4.
Mm-hmm.
And if we turn them away, I don't know what's going to happen. They're going to go out and use. Now they're in severe withdrawal. They're going to go out and use, and probably use too much. And I'm not going to take that chance of them going in overdose. You know, they've got all these other levels in between there, but nobody seems to know where they're at or where you can send them or get help trying to get them someplace else.
So in your area, you would say there's really nowhere else for me to send that
I
person?
have no idea where these residential level of cares or these other levels are.
Who else wants to comment on what they would do or how they would view a patient like this?
So if I'll speak from the health plan's perspective.
Yep.
If we
Yeah,
got
let's
a
say it's
request,
an anthem.
if we got a request like that,
Uh-huh.
we would want to know. I mean, it's already been mentioned, at least the information we've been given in the case so far is otherwise physically healthy person, 32-year-old, definitely in withdrawal. But, you know, the way we would look at it is everybody who is withdrawing from opiates is going to have opiate withdrawal. Everybody who stops using opiates, they've been dependent on opiates, they stop using opiates, they're going to have opiate withdrawal. But if you're trying to apply ASAM criteria, any other medical necessity criteria in a manner that is consistent with the criteria, we would be looking at what's not the risk of withdrawal, but what's the risk from withdrawal to the patient, to the member. And we would say that in this case, they don't meet criteria for level 4. They would not meet criteria for level 4. And we would try, and Anthem, for example, we have worked really hard to have a good relationship and strong presence of ambulatory withdrawal management in our network. So we would try to get them, you know, we would want our providers to get them to ambulatory withdrawal management, if nothing else. I mean, if residential is not something that's available right there, ambulatory withdrawal management is something that is, if it is available, and then we need to get them there. That's what. Now, unfortunately, from a health plan's perspective, what we get stuck with, I think, is that we can't necessarily, you know, we can help tell the provider that, you know, this is where the ambulatory withdrawal management is, but we can't physically get the member there immediately.
Yeah, so I think that's a really important aspect for our work group to unpack, how to provide you, all the collective you, to make sure you do know where they are, that it's a clear path, that we are working to build that those connections. And so I think at our next meeting we'll get together, and Dr. Zaire specifically has been working on some of those care transitions. So that's a huge area, and I get that only puts into high relief the kind of the issues that we're having, particularly for our inpatient providers that have always done that, will do that, that's what they do. So we need to keep hammering away.
No, excuse me, you're from Michiana Behavioral Health, right? That's what you said earlier. So for Michiana, I think, the closest place in our network where somebody could get ambulatory withdrawal management within 24 hours would be clean slate centers in Warsaw. That's 30 miles away from you guys. That's the closest you could. But there are other 2 places as well. One is in Elkhart and one is in Merrillville. So you sit between 3 different places, 3 different clean slate centers that are part of our contract, with whom we have a special program where we try to get members in. They are supposed to take our members within 1 business day of referral.
With 1 business day for somebody that's already in a pretty severe withdrawal or headed into it, and then we're supposed to send them home and wait for up to 24 hours for clean slate to get them in. They're going to be on the street using again.
Is everybody familiar with 2-on-1 and the open beds platform? I mean, I think this would be a perfect case where they're, in your office, is to utilize 2-on-1 and work with that navigator at 2-on-1. You can get into the open bed platform and see where there's an open bed anywhere in the state. So if this person might be more appropriate for, let's say 3.1 or 3.5, it takes some of the onus off of you or the provider. But if you get that person in a bed, and there are funds to support lift transportation to get that person from, if they're at your facility to the facility that they're going. So if it's not an appropriate level of care for the services that you offer, there is that option to utilize 2-on-1 to get that person into the appropriate level of care.
So while the patient is in our services, they're on our campus, that we're obligated to treat them. And if they don't meet the criteria for 4.1, what you're suggesting is that we call 2-on-1 and have them wait at our facility to make sure that they have arrangements to go to the next program.
I think building off of that, some of the things, and I know we're kind of running short on time, so maybe it's something that we document for further discussion. So it's my understanding that then somebody still has to go show, yes, there's an open bed, go here. They travel the 30 miles, they show up there, and then they're still, having to go through authorization processes and still may get denied and then have to be sent back and wait even further. So, I just heard that there's issues with warm transfers, that even if you do know that there's an open bed, somebody still may show up and there's not really a place to go. So I think it's just really focusing on some of the warm, actual coordinated transfers is still missing even in the open bed platform.
Okay. And I definitely think there's stuff that we can continue to work on, and if you do have concerns or you do have experiences, we at DMHA want to know that, so we can make this a seamless process as possible and not more frustrating for the providers, the consumers, or anybody involved.
I think an aspect that is positive that the health plans do offer is our case management. And so we have case management staff who are readily available to assist members who are not only discharging from an inpatient facility, but really any level of care. And for some of the providers, our health plans may be embedded there. We go regularly. Other providers, we're not as welcome. And some providers we don't hear from at all, despite our efforts to coordinate the members' care. And I think that is a huge opportunity that's been missed. Because if the level of care, let's go with the inpatient level of care, if that stay has been denied, our goal for our case management staff is to outreach and get coordinated with the members so that we can help them transition to a level of care that is a lower level, more appropriate, things like that. But it becomes difficult when we're not able to coordinate with that provider because they're not responding to our outreach.
Okay, so I want to grab that. I think the case management, I have heard, I think an area where Medicaid could assist in DMHA is the privacy aspect, because I've heard where some providers are saying they can't talk to a health plan due to privacy concerns. I think that's something we all need to come together on and find a common ground, because I am an attorney by trade, and I just need to know more about what the legal limitations are, and I'd love to talk to providers about that and see how we can break down any of those barriers, because that is a big deal. So I do want to flag that, but I kind of want to go back to a little more case discussion, and then what I would love before we leave, I want to talk a little bit
what's actually happening in the clinical on the documentation side. So this is all first impression, patient comes in, what we see, but can we spend a few minutes, because I get a lot of denials sent my way, and I send them to the folks here that can read them and interpret them. And I think one really salient thing that's going to come out of this is some instructions and how-tos on how to make sure you are documenting to get that approval. I think we see really inconsistent clinical documentation, frankly. And it's some providers that, there's a couple of providers that when I told the health plans, give me your best gold standard clinical documentation to support 4.0. It's the same providers that, on a different day, only check some boxes and the documentation's not there. But I will also give you examples where inconsistencies on the plan side. So I think it's all over. So I think we just need to really come together and try to get as streamlined and make sure you know what you need to put on there to get to the right outcome. And so if we can focus a little bit on that, and maybe this is, I'm already seeing a follow-up meeting in the works here. I will put a feeler out. We do get back together again on July 9th from 2 to 4. So we will have carrying conversations, but I'll hand it back to Leslie.
Yeah, I often review a lot of these denials, and I think what we see are boxes that are checked that indicate very severe symptoms, but then when you read the vignette or other information about it, it doesn't mesh. So I think that's a very common issue. So I think training providers to be able to convey what's really going on in the narrative is really helpful. Yeah, because it's pretty variable. Okay, so you submit. So you want us to keep walking through, right? So you submit this. So you fill out the form, fax it to your managed care company, right? And then you wait. How long? What did you guys experience?
Sometimes, for the pre-cert, there's a definite delay.
3 days on average for substance use.
Yeah.
3 days on average?
There's usually a delay on the pre-cert. Usually the concurrence we can get done and get a 24-hour turnaround, but pre-certs, and we usually only have like one contact person at each one of the health plans, and they'll say, well, it's still there, it's in process.
So you go ahead and make the decision before you get it?
Yes. And many times they're discharged before we can even get an answer.
Okay, and which is where not inconsistent with the way the acute care realm works, right? You do kind of do the admission and then that catches up, but what we have experienced is, I think we just need to all have the same level of trust in the system, so that's what we're trying to work through, so that way you aren't saying, there's always going to be a level, right? I mean, there's stuff that there are cases that fall through, but that providers have a joint kind of understanding of what ASAM is and what to expect. So I also want to flag that. I don't think we are 100% on the same page, providers and things yet, but
Okay, so the so you make the decision based on what you have available. You try to find something in your community. If you don't have it, you go ahead and admit. One thing I'm wondering is if I were an investor, I guess, which I'm not, but if I were, I would not personally invest in level 4.0 for opioid use disorder treatment, given the small percentage of the population that will be served by it. So I'm wondering about the community's thoughts on filling out the continuum of other, I bet I could get a lot of people into a 3.1. I'm just thinking, if you're doing the math on, is the plan gonna pay for this? I think what we're telling you for this patient, I think the answer is no. Probably ASAM would say no for this. ASAM would say, for the case I presented, so they're a moderate intensity. They would put them at a moderate intensity. They're probably homeless, so I think we could argue for residential level. They're not psychiatrically unstable. They're not medically unstable. So we could probably, if the person wanted intensive outpatient partial, that seems to work. And maybe a 3.1 would probably be covered, I'm guessing. And I think many patients fit into that bucket. And so I think our need for 3.1s and 3.5s is huge, right, around the state. And we have quite a lot of 4.0s. So we have we have a lot of, I shouldn't say it, we have a fair number of 3.5, but we need more of those, because the kind of patient that would fit in the 4.0 bucket is a rare person. Just the way and I'm not saying I like that, but that's how ASAM is designed, and that's what the state agreed
And
to
just
do.
kind of jump in a little bit, I was at all the ASAM trainings, and that was one of the things that they really harped on, was that, specifically for OUD, 4.0 is very rare. It's all the medical comorbidities, but then also suicidal ideation, homicidal ideation. I mean, very, very severe risk factors is what the facilitators, and these were the national facilitators, were saying that person would be appropriate for 4.0 level of care.
So I think the FSSA, OMPP, and DMHA have talked about the next phase of this is how do we partner, with your facility to talk about what are paths to having some more of the continuum. I mean, I think we are, for better or worse, like other states, we turned on a waiver and our providers were our providers, right? You were doing what you did, and then we pursued an SUD waiver and turned on all these additional options. And you're built a certain way and been serving your community. So I guess I just want to, underscore that none of this has been a growth process, and we've got a lot more to do. So we really want to continue to have conversations about, how do we diversify? How do we help you? What are there reimbursement mechanisms and different certifications? I know DMHA is trying to figure out how to round out that continuum. So I don't think it's not black and white today. The chips are not going to stay as they are now. But I think what we're trying to at least have an initial conversation of kind of ASAM on its face and comparing that to the Indiana market, where we have providers that have been doing just a heck of a job serving their communities, and we appreciate that. And now how do we kind of get to that next level, which is stability, which I think does absolutely involve some maturation when it comes to the stuff under 4.0. And we can't create providers overnight. We can't certify additional, do we even say certified delegates? You can't walk out of here 3.1, 3.5 and all that. But that's the kind of conversations we're having. We want to make it as, and I don't want to speak for you guys, but I do know we are trying to make that obtainable and something we can do. So at the risk of not running too long, are there any other, questions? I think we've unearthed a lot of stuff, right? I think you can expect from the Medicaid team in particular, we'll probably have like the top 5 or 10 takeaways that we're going to kind of package up for us to keep us focused on in continuing to set priorities for this group to continue to stabilize and expand the network. But any questions or feedback? We will be back together July 9th from 2 to 4. Mike, do you have anything?
I guess I would just, the things that strike me is partnership and timing. And the patients who are at our doorstep, if we can establish the partnership to assist us in getting the patient to the proper level of care in a timely fashion. If I have to wait 72 hours, and I'm saying that that's a struggle for us, because we're seeing what's in front of us. We're the only ones seeing the patient that's in front of us. And we have to make that determination by ourselves with criteria.
Yeah,
using
you got your
criteria.
book.
So how do we partner with the managed care entities
I
on a
don't,
timely period?
and I'd like to just add to that, because like you said, we have the patient there in front of us, and it's not like you can look at a patient and know what's going to happen. And I'm going to give you 2 quick scenarios just within the past week. If we had not admitted this gentleman and then a few hours later noticed the change, we ended up having to Narcan him and send him out. He was admitted to CCU. Another case, somebody that we went ahead, we admitted, and within a couple of days, he continued to decline. and we had to send him out, and he ended up having endocarditis. You can't see that stuff up front, but these are people's lives. So,
I will add, though, that one of the things that we as health plans, I think, have all universally stressed is a facility can do observation. It doesn't require prior authorization, and it can be up to 72 hours. What we hear back in return is that that's not something that they can offer. I've never quite understood
Well,
that.
I'm going to put a pin in that too. That is something we are actively talking with CMS and industry about, and what should be able to provide an update at the July 9th meeting. So, understood.
And just real quickly, I know we've talked a lot about ASAM, and we did have some trainings in April. We are going to be having 9 more, sometime probably starting in fall through April 30th. I'm working with ASAM right now to get dates, so we're looking at potentially basically having 3 in the north region, 3 in the central region, 3 in the south region, roughly 50 people per training. At those, you will get an ASAM criteria book. We will probably have the first training in central. So depending on where I can find places to donate their space, is where those will be held. But realistically, probably one maybe in Indianapolis, one maybe Terre Haute, one maybe in Richmond, and we'll go probably to the south region. And then the north region will probably be in March or April when it's a little bit warmer, so we don't want to get stuck up there in snow. But as soon as we get those dates, we will get those distributed out and the registration links so you guys can get signed up for that.
In the July meeting, will we talk about the collaboration more, because that seems like it's a big issue?
Yeah, we will make sure that is a very robust portion, and there may be some free work for us to do, but yes. Yes. Amy?
And then I think just as a part of that discussion, you know, if level 4 isn't appropriate, it's a big jump to say, well, if level 4 isn't available, go to clean slate, which I don't, and you know, as we all, for those of you that don't know me, I'm not a clinician, and don't pretend to be one, but it would seem that's a big jump, and so I keep hearing level 3.1, level 3.5, but that doesn't necessarily exist in the real, for all intents and purposes. I mean, so, and it may, and there are beds, but the volume that needed far exceeds that, and so absent a level 3, what do you do with that patient knowing that they need way more than a level 1? And so I just think that we need to put that on the table as we discuss what the options are, and it may be to your point that certainly there is more investment needed in level 3.1 and 3.5, but until we get there, how do you take someone that needs that level and say, we're going to stick them in level 1 and not provide those other support services? So I just put that out there as part of that discussion in the gaps in the system and how do we get to where we need to be.
I would just say there's so we have an Excel file literally that I was looking at an hour ago that lists all of the current 3.1s and 3.5s, the applications in process, and there are a ton of them. And the numbers of beds that they have a column that's like numbers of beds available, there's tons. So it's, I mean, I think it's just not going to be 20 minutes.
Publicly available.
So what's the best place for folks to find out about providers?
Probably, I mean, through the DMHA website, there's a link that says find addiction provider, and you can click what level of care, it's a specialty population, so if you're looking for a female, pregnant female, and then it can be brought down, basically down by your area, so what's closest in your area.
Yeah. And I talk to providers all the time, and they complain that they're bored and that they are like in danger of firing staff because they don't have enough patients. So we have this, you know, like we have to figure out how to connect them to the hots more.
All of them, like most of them?
What?
They're medicated.
Yeah.
all of them.
Yeah.
So a good point, Amy, and I do think that, again, back to the connections and the collaboration, that database, so critical, because we can't,
And to your point, you know, they may be good enough for level 1 withdrawal management, but they need 3.1 for their treatment. So that's the other thing to keep in mind. For withdrawal management, they don't need 4, they need level 1, but for the treatment, they need something residential. So again, so clean slate may be good enough to get them started, stabilized quickly for withdrawal management, and then in the meantime,